So now we're going to take a look at exactly what cortisol does, and then as we look at cortisol, and we'll look at the androgens as well, we'll look at what it normally does, what it happens if the levels are too high, and what happens if the levels are too low, so we can kind of understand the pathophysiology of Cushing's and Addison's at the same time. So with glucose metabolism, so what happens is, by increasing the expression of phosphatidylpyruvate, carboxykinase, glucose 6-phosphatase, and fructose 2,6-bisphosphatase, you get induced gluconeogenesis. Gluconeogenesis. Then it acts as a permissive signal allowing lipolysis. In skeletal muscle, you get activation of the ubiquitin pathway. Ubiquitin. I'm not even going to spell it right. But the purpose of this is to free up amino acids. You're going to break down proteins. You're freeing up amino acids and you're causing lipolysis so that you can get gluconeogenesis in the liver. So the main purpose of this with insulin, the main purpose of this would be to maintain euglycemia. So in the liver, whenever you get this gluconeogenesis through cortisol stimulation, you're going to have increased blood glucose, but you're also going to have increased glycogen stores. So with Cushing's, you're going to have slightly hyperglycemic, and you're going to have excess glycogen stores. With the action on adipose tissue, you got to remember that cortisol is acting with insulin because glucose is going up, so you're also going to get the pancreas to start producing increased insulin. So together with insulin, you get central fat deposition. This is going to cause a couple of things. So first of all, you're going to get belly fat, increase in belly fat. You're also going to get what's called the buffalo hump and moon facies. I like the word facies. It just sounds weird. Moon facies. Now I didn't say feces, even though that kind of looks like an E. That's facies. So with Addison's, on the other hand, you're going to have decreased hepatic glucose output. You're going to also have decreased glycogen stores. You'll have decreased lipolysis and decreased adiposity. So with the muscle breakdown during Cushing's, what you're going to have is muscle wasting. So I'll just write wasting here. And you also get an increase in nitrogen excretion in the urine. With Addison's, you don't necessarily get wasting, but you get weakness, and with that, it's due to decreases in glycogen stores. And then lastly, so we said we get hyperglycemia with Cushing's. With Addison's, you get hypoglycemia. To make a few summary statements, you get muscle wasting. This happens through two mechanisms. You have a decrease in the mTOR, which is a protein synthesis, and you have an increase in ubiquitin, specifically the MAFBX and the MERF1. These ubiquitins free up amino acids to be used by the liver. With adiposity, it's slightly paradoxical. You have competition between lipolysis that's activated by cortisol and the increased insulin, but that competition ultimately you get the increased adiposity possibly by an increase in leptin production, and that high leptin production causes an impaired satiety, so you don't know that you're satisfied, you keep eating. So the next thing to take a look at is calcium homeostasis. And the big thing to know about this is that glucocorticoids, they will negatively impact the action of vitamin D. And what that means ultimately is that we're going to have decreased calcium absorption from the GI tract, and we're going to have increased calcium excretion from the kidneys. And vitamin D is also big for absorbing phosphate, so we're going to also get increased excretion of phosphate from the kidneys. So the term for this is hypercalciuria. But you would think you might get hypokalemia. That's not the case because our parathyroid hormone is still going to be working just fine. And although we're excreting excessive amounts of calcium from the kidney and we're not absorbing nearly as well from the GI tract, parathyroid hormone can still act on the bones to reabsorb calcium. So in some cases with a Cushing syndrome, you're going to see a hyperparathyroidism, which is secondary, but that's not going to be in every case, just in some cases. And this also points out the effect of glucocorticoids on bone slightly. With both Cushing and Addison, you're going to have decreased bone growth. With Cushing, however, you would think, oh, it's because of the action of parathyroid hormone. That's not necessarily the case. The main case with Cushing is that you have decreases in collagen synthesis. Remember, we're decreasing gene expression using glucocorticoids, and so by decreasing the gene expression, we can reduce the synthesis of collagen. With Addison, on the other hand, what we get is a decrease in growth hormone, and that will negatively impact bone growth. So in summary of this, you're going to get osteopenia and hypercalciuria. This is due to a decreased production in vitamin D, well, and not a decreased production, but a decreased activation. With the decreased activation, you get urinary calcium excretion and decreased GI absorption. With that, you'll induce an increase in PTH, and PTH will cause bone resorption. Also, cortisol can stimulate the production of rank or rank L in osteoblasts, and these osteoblasts will secrete that which will activate osteoclasts. You can have a decrease in menses with both Cushing and Addison's disease. Now here's the basic idea of why. First of all, if you have increased cortisol, regardless of all the rest of this stuff, it's going to change the pulsatility of gonadotropin-releasing hormone. It's going to change its impact on the anterior pituitary, leading to anovulation and amenorrhea. You can have increased cortisol with different types of Cushing syndrome. For example, a cortisol-secreting adenoma in the adrenal glands, or an ACTH-secreting adenoma, or a CRH-secreting ectopic tumor, which is very extremely rare. And in which case, anytime you have an increase in either CRH or ACTH, ACTH is produced from the cleavage of a protein called pro-opiomelanocortin. Pro-opiomelanocortin also contains cleavage products that become endorphins. Endorphins will also change the pulsatility of gonadotropin-releasing hormone and change its impact on the anterior pituitary. So with Addison's, what you have is the adrenal glands failing to produce cortisol, and you remove the negative feedback that it would typically have on CRH. This induces an increase in CRH, which induces an increase in pro-opiomelanocortin, and you have an increase in opioids. So in this way, you get amenorrhea or oligomenorrhea from both Cushing and Addison's disease. Now also with an increase in ACTH, ACTH will act on the adrenal cortex to increase the production of androgens. I'm just going to put andro. And androgens will also feed back and inhibit the pulsatility of gonadotropin-releasing hormone. Ultimately, with the decreased GnRH pulsatility, what happens is you get low FSH and LH. And this is going to have two different distinct characteristics in men and women. So for women, they normally don't get hardly any androgens. So this is going to be a lot of androgen for women. But for men, we make way more androgens than this in the testes. So where is this androgen coming from? Like I said, this is coming from the adrenal gland. And the testes produces a ton more androgens than the adrenal gland normally does. However, the low FSH and the low LH, without LH, you don't get any production of androgens in the testes. So with men, you get symptoms of low T. With women, you get hirsutism. So hirsutism is whenever you have more androgens than you normally do. So women have symptoms of high androgens, men have symptoms of low androgens. So to summarize this, with ovulation, you get an increase in pro-opiomelanocortin, which increases opioid production, altering GnRH pulsatility. With the alteration in pulsatility, you get low FSH and low LH. Also, the increase in cortisol will alter GnRH pulsatility. In women, androgens will also be produced, causing hirsutism. In women, the low LH and FSH end up resulting in anovulation. In men, it results in low T and also in a low sperm count. Now, I already talked a little bit about how the blood glucose homeostasis is interrupted by excess cortisol, but I want to take a second and point out that you also get an increase in insulin, but the increase in insulin, it's not as much as you would expect for how high the blood sugar is. So overall, through glucose, insulin is increased, but through cortisol, insulin is decreased. So you have two competing mechanisms. The blood sugar wins out just a little bit, but it's a lot lower than you would expect it to be. Now, down here I have my pancreas, and we're going to zoom in under increased magnification and take a look at why that is exactly. So what we have here, this is the normal way that insulin gets produced and excreted. So you have this GLUT2 transporter, and it allows glucose to move into the cell, and the glucose gets transformed into ATP. So GLUT2, you'll remember, they're constitutively active channels. So anytime there's glucose out here, it will always flow down its concentration gradient into the cell, get converted into ATP. Now typically potassium will constantly be seeping out of this potassium ATP channel, but whenever ATP is in a high concentration, it will actually turn off this channel. Whenever the positive charge can't move out of the cell, the total charge inside the cell builds up and it depolarizes. Once it depolarizes to a certain threshold, it opens up this voltage-gated calcium channel, and calcium will flow in. Calcium will have two actions. First, it will act through this calcium response element binding protein to increase the production of insulin altogether, and it will also act on these vesicles that are storing insulin and cause them to be released. So the input from calcium causes both the production and secretion of insulin into the blood. What cortisol will do is it actually interrupt this process right here. It interrupts the calcium-caused exocytosis. So although you can get some exocytosis, it will not be nearly as much as you would expect for the amount of calcium that could go into the cell. So this is called total hyperinsulinemia, but relative hypoinsulinemia. It's hyperinsulinemia because you have more insulin than what is considered normal, but it's hypoinsulinemia when you look at the amount of blood sugar. So to summarize this, you get hyperinsulinemia, which is a relative hypoinsulinemia. The hypo because cortisol is binding to the voltage-gated calcium channels, but the hyper because you have insulin resistance in the periphery. So with the increased gluconeogenesis caused by cortisol, you also have a decrease in insulin response substrate 1 in both the liver and the muscle. So insulin cannot act on the liver and the muscle because IRS1 is decreased. You also have an increase in substrates. You get lipolysis and amino acids in the muscles from ubiquitin. You have a decrease in adiponectin. That's in the adipocytes, and the adiponectin is basically how the adipocytes respond to insulin. So IRS1 in the liver and muscle, adiponectin in the adipocytes. Then you have a decrease in osteoclastin, and this mediates the bone glucose homeostasis. So there are 5 basic etiologies of insulin resistance. Another thing that you get with cortisol and glucocorticoids is you get a decrease in the amount of binding proteins because we're inhibiting their production. It's acting as a gene transcription inhibitor. So things like sex hormone binding globulin, CBG, thyroid binding globulin, all of these things will get decreased in their production. So do you get an excess of free hormones? The answer to that is no, because, for example, let's take thyroid, for example. When the amount of thyroid binding globulin is decreased, so we have decreased thyroid binding globulin, we'd get a transient, it's going to cause a transient increase in T3 and T4. However, that's going to immediately feed back and inhibit the thyroid releasing hormone and the thyroid stimulating hormone in the anterior pituitary. So you would get a decrease overall in T3 and T4 production. And that will continue until the free T3 and T4 is what your body needs. And so even though you have a decrease in thyroid binding globulin, you don't have any changes in the free hormone. However, you do have a reduction in reserve. Your reserve hormone is changed, it's depleted. Now this would be an effect of Cushing, but you don't see the opposite with Addison. Your body knows it wants a certain amount of binding globulins and binding hormones, and it will keep trying to make those until it gets there, and when it gets to the level it wants, it stops. However, with Cushing inhibiting that, you don't get an increase with Addison. Now, cortisol will have an effect on the immune system as well. In the thymus, it can cause involution, and so you can get a smaller thymus over time with increased cortisol. So this would cause a decrease in lymphocytes with Cushing. With Addison, you get a relative increase in lymphocytes. So that would be lymphocytopenia versus lymphocytosis. Monocytes, you get the same thing, a decrease in monocytes for Cushing, increase in monocytes for Addison. With granulocytes, however, you get something different. And let's take a look exactly what happens here. So we have our vascular endothelium right here. So this would be a blood vessel. And inside the blood vessel, you're going to have some granulocytes. And let's just call these neutrophils. So these are all neutrophils. And then we're also going to have some neutrophils that are adhered to the endothelial surface. Now, if you were to take a blood draw, let's say we stuck a needle in here and we were sucking out some blood, we're only going to be able to pull in these neutrophils right here. The neutrophils that are stuck to the surface are not going to be included in your count of neutrophils. However, cortisol will cause a decrease. It'll cause a decrease in adhesion proteins. So it suppresses the adhesion proteins and it causes these to come off of the side of the vasculature. This is called demargination. Now, since we're talking about blood cells, I want to point out something about the erythrocytes. With cortisol, there really is no effect on erythrocytes. However, in some cases, you can have an increased hematocrit, an increased amount of red blood cells, but that is mostly due to an androgenic effect. So if you have an ACTH secreting adenoma, you would expect to get an increase in androgens and possibly an increase in erythrocytes. This could also be seen with an adrenal carcinoma or anything that would increase the amount of androgen secretion. Then the last thing with the immune system is the inflammatory response. The first thing you're going to see is a decrease in leukotrienes and prostaglandins, and this is by decreasing the activity of PLA2. And the other thing you're going to see is a decreased expression of cyclooxygenase 2. These things work together to decrease any type of inflammation or inflammatory response. However, the amount of decreased inflammation you see is going to be directly related to the amount of glucocorticoids secreted. Okay, so summary of the immune response is you get an increase in white blood cells due to demargination. That's mostly going to be neutrophils. You get a decrease in lymphocytes. This is a couple of things going on. First, you have induced apoptosis of lymphoid tissue, the thymus, the spleen, and the lymph nodes. Then secondly, with a reduced inflammation due to an increased production of annexin, which is also known as lipocortin. This annexin or lipocortin actually inhibits phospholipase A2 or PLA2, and altogether this can result in a decrease in leukotrienes, which is like IL-2. IL-2 is one of the controllers of lymphocytes and their migration pattern, where they're going to go, what tissues they're going to move into. So that is also going to inhibit the immune response and decrease the number of lymphocytes. Then also this annexin may play a role, or just cortisol by itself may play a role in inhibiting the COX-2 expression. You'll notice the effect of Cushing in the skin because cortisol is going to decrease the activity of fibroblasts and keratinocytes. With the fibroblasts decreased, you're going to have increased striae. Both of these things lead to increase in bruising and decreased wound healing. However, one of the key phrases in Cushing's is hyperpigmentation. How does that happen? Part of it is due to the striae. However, another part of it is due to this pro-opiomelanocortin. Under the stimulation of corticotropin-releasing hormone, you get the production of this protein. The reason for that is because this protein gets cleaved into ACTH, as well as melanocyte-stimulating hormone, lipotropin, endorphins, and so on. And so you can see where its name comes from. Opio, because you get endorphins, melana, because you get melanocyte-stimulating hormone, and cortin, because you get adrenocorticotropic hormone. Now you'll also notice the ACTH is made up of this piece that can be clipped off, as well as alpha melanocyte-stimulating hormone. Alpha melanocyte-stimulating hormone has much, much greater activity than the gamma or the beta or ACTH at stimulating melanocyte production. However, ACTH and this beta and this gamma cleavage products can all act to promote melanocyte stimulation. And they'll typically act on the MC1R receptor to promote melanocyte production, or rather melanogenesis, not the proliferation of the melanocytes themselves, but the production of melanin. Anyhow, so most of the sources will just say the increase in ACTH will act on this receptor. However, some sources will say that because you have an excess or a backup of this protein, that you can get all these other cleavage products from that as well, and basically an overproduction of melanocyte stimulating hormone. So whichever one that is, I don't think it really matters clinically, except that you know you're going to get an increase in pigmentation. Now here's a key point. Because this is under the influence of corticotropin-releasing hormone, this can also occur in Addison disease. Addison's disease. And why is that? Because in Addison's disease you have a primary deficiency of the adrenal glands, so you have decreased cortisol. And with decreased cortisol, this is released from the inhibition, and so you get increased production of pro-opiomelanocortin. To summarize the dermatologic changes, you get a decrease in fibroblasts, which ultimately results in a decrease in connective tissue. Without connective tissue, you get thinning of the skin, striae, especially with weight gain. And remember, the striae are not just going to be from this thinning of the skin, it's also going to play a role in the pro-opiomelanocortin that we just talked about a few minutes ago. But just note that there are two different kinds of changes in skin color. The striae specifically are going to be reduced connective tissue. You get easy bruising and poor healing due to this decreased connective tissue. Then also, low connective tissue plus hypertension results in edema. I'm going to talk about the cause of hypertension here in just a second, so bear with me. The last dermatologic change we talked about already is hirsutism, so you already know how that happens. With Cushing, another thing you normally see is a high blood pressure, and what causes that is two things. So first of all, cortisol will augment the catecholamines. Catecholamines do what? They increase heart rate and contractility, and they increase peripheral resistance. The increase in peripheral resistance is usually from the contraction of the vascular myocytes. And not only that, but cortisol can act on the same receptor that aldosterone acts on in the kidneys. To explain this, I'm going to try to explain the cortisol-cortisone shunt. Now, cortisol and aldosterone have the same affinity for the mineralocorticoid receptor, which we've drawn right here in the kidney. They have the same affinity. So how does cortisol not always act on it? Well, The answer to that question is cortisol, when it goes into the kidney, it gets acted on by 11-beta-hydroxysteroid dehydrogenase 2. Cortisol gets converted to the inactive cortisone. That gets repackaged, reabsorbed, and sent over to the liver. The liver takes cortisone through 11-beta-hydroxysteroid dehydrogenase 1 and converts it back into cortisol. And so this circle is known as the cortisol-cortisone shunt. When you have so much cortisol that it overwhelms the function of this enzyme, then you get some of it that will come down and act on this receptor and have a mineralocorticoid activity, such as aldosterone activity. And what does aldosterone do? It increases sodium reabsorption and increases extracellular fluid, and at the same time it secretes potassium and it secretes hydrogen ions. So you can get an alkalosis and hypokalemia. Depending on the type of tumor that we have secreting the cortisol, or maybe it's secreting ACTH or CRH, but depending on the type of tumor, you may also get something called symptom of inappropriate antidiuretic hormone, and in that case you would have decrease of sodium. In other words, hyponatremia. With Addison's disease, we get the exact opposite of all of these things, but it has nothing to do with cortisol binding to a mineralocorticoid receptor. Basically, what it has to do with is that you have failure of the adrenal gland, and so you have failure of aldosterone to be produced. So with hypertension, there are 4 basic mechanisms. We discussed the mineralocorticoid effect of cortisol whenever you have an overload on 11-beta-hydroxysteroid dehydrogenase. Now, when you see this, you're going to see low potassium, high sodium, and possibly even alkalosis. This is because the reabsorption of sodium causes potassium to be excreted, and then also you get in the alpha intercalated cells, you get the secretion of hydrogen ions with cortisol. Whenever cortisol excess was first discovered to cause hypertension, the theory was that this was the cause of the hypertension. But people treated with spironolactone, which actually blocks these receptors, they didn't get any better. Their hypokalemia went away, their hypernatremia went away, the alkalosis went away, but the hypertension just barely was touched. And so that started people looking for other mechanisms. Next, reduced nitric oxide synthesis was discovered, and then an effect with the renin-angiotensin-aldosterone system, possibly that their receptors are increased. That was kind of the next thing that was discovered around 2004 or 2003-ish. And then I think most recently it's discovered that alpha-1 and endothelin receptors are increased, so you get vasoconstriction whenever the catecholamines bind to these receptors. The easy way to remember this, perhaps, is if you look here, you have mRNA. So, like messenger RNA, if you think of it like that. And that's mineralocorticoids, renin-angiotensin-aldosterone receptors, nitric oxide, and alpha-1 and endothelin receptors. And this mRNA is carrying transcribing the gene for hypertension. Really quickly, let's talk about psychiatric changes with Cushing and Addison. With Cushing, you're going to get an initial euphoria. However, long term, it's going to change to depression and psychosis. With Addison's, you just get basically depression, no euphoria. So sorry, Addison's. With Cushing's, you're going to get hyperphagia. With Addison's, you're going to lose your appetite. However, with your decreased appetite, you also have increased taste and increased smell. So it's kind of a contradiction. That smells really good, but I don't want to eat it. With Cushing's, you get depression of REM sleep. I couldn't find anything specifically on Addison's with sleep. And with Cushing's, you're going to get impaired hippocampal memory formation. And it can actually cause hippocampal atrophy after a long term. With Addison's, again, I didn't find anything on memory formation.